Good afternoon, everybody. We'll make a start. Thank you all for joining us this afternoon. This is the third and final webinar of today's series. We've had two really interesting webinars in on today, so I'm sure this one will be no different. Richard, no pressure. So with this, we're going to talk a lot about Frailty, and there's always a lot of conversations around Frailty decisions. So we will dig into it as soon as possible. So we'll have a chance for some questions later on. Richard will have a short presentation, but first of all, I just wanted to sort of gather a sense so Richard and others can see who's in the room, and who is with us today. So we've got a short Menti question to ask everybody to log in first. If you wouldn't mind just scanning the QR code on your screen now, that will take you to a Mentimeter question in a moment when I move the slide forward. Thank you everybody for ticking the thumbs up sign. So we've got about 28 people in the meeting and the numbers are increasing. Thank you very much. It's brilliant. Thanks Lucy for posting the code in the chat as well if anybody's using desktop or laptop. Just while a few more people log into that, we'll come back to this at the end of the session, so please stay logged in on your phones if you're on your phone or on a second browser on your laptop or desktop PC. So the question we wanted to ask to start off with is just literally who's in the room today. What's your professional or role within your organisation, just so Richard and others can get a sense of who the audience is. Been a real nice mix across the other previous two webinars today. We're looking for a nice diverse mix. So we've got a reasonable mix here, lots of doctors, which is great, a few nurses, and one other. I'd love to know what that other is. I was trying to think of the different professional groups who I've missed out. Please let me know in the chat room what professional group I've missed out. Could be retired actually, could be people who have joined us and have been retired. So that's fantastic. So that's wonderful. That gives everybody an understanding about who's here and how we pitch some of the conversations. Perhaps please stay logged into that because we'll come back to that at the end of the session. But I'm going to hand over to our chair for this session, Jyothi Nippani. Jyothi, over to you. Jyothi, you on mute?
Good afternoon, everybody. I had to do it once at least in a day. So good afternoon, and I see some really known familiar names in the audience. Adrian Hopper, Jagdeep Desi, thank you all for joining. So this is the third of our series of our specialty webinars. And these specialty webinars are aimed at giving a national push on the guidance that has been developed by the specialties themselves or by their networks or by the Royal Colleges or the societies. So just giving a national push, that's the first aim. And the second aim really is to learn how clinicians in the front line, in the trust, have actually implemented these guidelines. What challenges have they faced? What were the enablers? And thirdly, it's really about understanding how we can get our senior clinical decision makers from our specialties to own these patients early on in the patient journey so that our patients get to see the right team first time or very early on in the patient journey, that minimizing the patient waits. So that's the real theme of these specialty webinars. Now, the Frailty one is being done by Richard Genever, who is a consultant geriatrician from Chesterfield, and he's also one of our clinical associates from ECIST. And he was meant to be joined by Adam Bruning, I think, and Adam has given, is probably not joining today, but there are loads of geriatricians on this call. We'll all help you, Richard. Take it away.
Thanks, Jyothi. Yeah, let's just get my screen up and running. Yeah, so as Jyothi said, unfortunately, Adam's had to pull out of this at short notice, but he's given me his slides, and so what I'll do is I'll discuss his slides, describe them, and we can certainly talk around them. And if we've got any specific questions about the bit that was his bit, we can certainly forward any of those to him. So I guess the idea of this session is to look at ways that we can close the gaps between what we're able to do right now and what we want to do to help people living with frailty. So I'm going to share a bit of data that I think helps us to understand what's going on, and also that I find really useful in clinical conversations. I'm going to take you through the Frail strategy, which is the piece of work that Adam has been working on, and then perhaps talk a bit about things that might be realistic changes in the way that that you do things potentially. But what I really want to do is to open things up to discussion. So I want to make sure that we leave enough time for that to happen. So the situation that we'll all be familiar with is just all of our hospitals being chock-a-block. And the question is this down to rising admissions? Is it down to reducing discharges? Or maybe it's a bit of both. So here's some data to help us to understand the problem. So this is looking at the Midlands and the East regions, and it's coming from the ECIST urgent and emergency care dashboard. And you can see that there is this really kind of regular pattern of rising admissions during the week, reducing during the weekend, but overall the pattern is pretty stable. However, if you look at long length of stay for the same area, so this is people that have been in hospital for 21 days or longer, you can see that across these two regions, it's gone up from a little over 4,500 at the beginning of July to over 5,000 now. So there is a big increase in the number of people in hospital for a long time. And when people are in hospital for a long while, one of the consequences of that is that we can lose control over outcomes, and I'm going to show you some reasons why I think this happens and some evidence that it does happen. And then when we lose control, we get more fatal and non-fatal deteriorations in patients, and then this leads to increased length of stay and this vicious circle that goes on. And normally, urgent and emergency care lives in the realms of the complex. So there are many factors that define what happens to people. You can't be certain that if you do action A, then response B will come out. But there are ways to kind of manage for that, things like safety netting, for instance. But when we're working in organisations that are completely full and flow is non-existent, those processes are dragging us towards the sort of chaotic area where we've got less impact potentially, and we're getting into this cycle of constant firefighting. So what I want to do is to look at ways that people living with frailty affect that and what we can potentially do to influence that. So one way to try and understand complex situations is with the use of simulators. And so here I have to give enormous thanks to Chris Green, who is the head of information for ECIST. So I said to Chris, I'd like us to create this simulator that kind of represents what might happen to somebody who is in hospital for a little while. I want it to show that they could get better sometimes and maybe they'll get worse at other times. And amazingly, he came up with exactly what I'd sort of got in my mind. So what this represents is somebody presents to hospital with an illness, and they are assigned a level of health, and in this case they start off with a level of 5, and then with each cycle of the simulator their health will probably increase or it might reduce, and if it does reduce, it can reduce by varying amounts. If you get to the threshold, which in this case is 90, you escape, and that equates to being discharged from hospital. If your level reaches 0, then effectively that person has died. And so you can see there are two lines here. So the red one has gone up, has a little bit of a wobble, goes down, and then gradually increases and escapes. The blue one improves, then reduces, then improves again, and then suddenly hits 0. So this gives us an idea of the kind of things that happen to people that are in hospital. And so if you run this loads of times, you get something like this. So in this case, there are, I think there's 6 people that reach the threshold, which is about just over a quarter. There's 10 that reach 0, and there are, I think, another 6 that neither reach the top or the bottom quarter. And so this gives you an image of what a particular pattern might have. So you can see within that, you know, there are lots of ups and downs of these sort of trajectories. Now, what we've done here is we have set a lower target to escape. Now, that could represent different things. It could represent saying that we're aiming for a different level of recovery in terms of their health in order to get out. It could be that we're trying to remove other obstacles to discharge. But if we set a lower target, so in this case we've reduced it to 50, 80% of the lines reach the threshold, whereas only 20% reach zero, and in this case none went to the point where it neither escaped one way or the other. So our kind of theory that I think the simulation proposes is that with longer length of stay, and there are different things that might drive that, we lose some control over our outcomes. Now, it doesn't mean that you will definitely get better outcomes or worse outcomes with one or the other, but I think your ability to control what happens is ceded when you accept a longer length of stay. So does this happen in real life? So this is some data from an acute district general hospital looking at in-hospital mortality. It comes from Dr. Foster Intelligence. And if you look at the date, it's 3 years prior to COVID, to take out any sort of factors that COVID might have made. And what I want you to look at is, so this represents so in-hospital mortality broken down into 6 different lengths of stay, from 0 days up to 28 days plus. And for patients over 3 weeks in hospital, the overall crude mortality was 12.9%. So the question whenever you're sort of presented with a figure like that is it a big number? And so to compare with 12.9%, I give you the figure of 12.5%, which is the mortality rate for British soldiers in the First World War. So immediately we've got the ability to kind of weigh up the risks and benefits of being in hospital. Now, that high mortality is something that is down to loads of different factors. Some of it's down to the illnesses that bring people into hospital, but some of it is down to things that happen to hospital that when people stay in for a long time, particularly frail older people. And so when we're trying to work out whether we keep people in hospital in order to answer a particular question or deal with a particular problem, actually what you need to think about is, or what's the alternative and what is the risk of that thing? And so we know that people that are in hospital for long periods of time do carry high risks of dying. And in fact, even if you look at people that are in for 1 to 2 weeks, it's still 7.5%. So that's still a pretty high figure. So you don't have to be in for 3 weeks for the risk to be as high as you might worry about. So is this still a factor, and does it relate to all hospitals? So this is all non-specialist acute trusts, and it's looking at the last 12 months. And this is for anybody over 3 weeks. And you can see that the average mortality rate for those patients is 12.3%. So it is a high figure, 1 in 8, and something that I think we need to take very seriously. Okay, another thing to think about when we're considering what happens to frail older people in hospital is trajectory. So an admission to hospital, particularly an unplanned medical admission, can be a sentinel event. It's something that predicts actually some quite serious things that would happen to that person. So if we look at, so this is taken from a paper from Moore et al. From the BMJ Open. And it's just from 2018, so very recent. This shows what happens to people who have had an unplanned medical admission. And for people aged 85 or over, if you follow them up for a year, 42% of those people are no longer alive after a year. 42%. Again, I would say a very big number. If you imagine this is a ward, and you're looking at people that are sitting in that ward, over time, the number of people still alive from that group is going to reduce dramatically. So so think about that in terms of how we value people's time. So we'll all be familiar with the last 1,000 days, well, actually, for people over 85, maybe it's the last 100 days or lower than that. So this time is really, really important. Also, when we're keeping people in, particularly for clinical reasons, what is the thing that we're trying to fix? And is it likely to make an impact in the time that this person has remaining? So thinking about trajectory is really important in terms of decision making. So coming back to that sort of vicious circle I showed before, the question is, what can we do to reduce length of stay? Because by reducing length of stay, we could potentially lead to fewer fatal and non-fatal deteriorations, which will then lead to more control over outcomes, which then leads to further reduction in length of stay. And what I'm hoping we can do is explore some of those things, both in the remaining part of the bit I'm going to do, but also in our discussion. So what I'm going to move on to now is the section that Adam was going to cover about the Frail strategy. So this is something that's being promoted by NHS England and is actually happening in 8 trusts around the country at the moment. And the sort of origins of it come from the perhaps long forgotten NHS long-term plan. So in 2019, there was the ask that acute frailty services would be provided for 10 hours a day, 7 days a week, with clinical frailty assessment within half an hour. And some sort of data to give you a bit more background. So, so as of last year, just under half of sites were delivering that number of hours, but the mean average weekly opening time was 61 hours per week. I presume this is from trusts that do have some sort of frailty service as such, because there's still a significant minority that don't. And other factors that have or will influence things is that we are living in an aging population. So the increase in people aged 65 and over, but actually a very significant increase in people aged 90 and over, so almost 100,000 more over the last 10 years. And so with that comes this additional burden of frailty. And one of the concepts is that there's, rather than this traditional system where you've got people who are at home and then they get admitted through an emergency department, and essentially the only option you have there is admission. There's perhaps more of a continuum from people living at home, working with community-based teams, having clinical conversations with specialists that maybe lead to a more nuanced set of options. So it might be admission, but it might be going into a frailty SDEC or going onto a virtual ward or something else. And the hope is that by using these sort of approaches, it may increase the number of people that are able to return to living in their usual place of residence or something closer to it. And so here's the sort of the big idea. So it's based on the 5 letters of the word frail, so focusing on the acute problem, and also assessing or identifying those people with frailty by using the clinical frailty score, making sure that people who are frail are referred for MDT assessment, that there is CGA assessment goes on, that process leads to the identification of what that person's needs are. And I'm going to talk a bit more about identifying needs in a bit, and that people leave areas like emergency departments or acute frailty units as quickly as possible. So a little bit more detail. I'll perhaps draw your attention to the recommendation for a triple assessment for assessing frail older people. So using news to look for sort of physiological derangement, the clinical frailty score, which can be completed in about, I think it's about 12 seconds on average to complete it, particularly if you use the app. Reminder that it's for people aged 65 and over only. And then the 4AT is a rapid way of detecting delirium. There are actions that are recommended at provider level and at ICS level. And I guess what I'd want to say about that is that both of these are important. I think if you're working in a provider, I think it's not, I think if you say, well, all the problems are outside of our organisation, it's all down to lack of social care, lack of care homes, then you're never going to improve. On the other hand, if you don't engage with other people working within the health and social care environment, you're going to miss opportunities. So I think both are important. But yeah, you certainly have to look at what you could change within. So the referral bit, I guess this idea of pulling into frailty units, as well as a push from emergency departments, is one that's really important. All of these slides will be made available, so I won't go through them in precise detail. So I think the thing that stands out here is that the clinical frailty score of 6 was chosen for this particular project. Some frailty services will use a lower score than that. And so my understanding is that the score of 6 was chosen as a kind of pragmatic one to perhaps get more engagement with the process. One of the things I will talk about is perhaps having an evolving clinical frailty score that uses your threshold depending on what your service can provide, and if that increases over time, your abilities to take on more, then you can push the score down. So identifying needs, again, it's about sort of personalised assessments, personalised care, that sort of thing. And then getting people moved through and ideally home. And one of the key principles of the Frail strategy is that SDEC is the presumed route for people that go through a frailty assessment. Just spotted somebody popped a thing in the chat about the difficulty assigning accurate clinical frailty score within 30 minutes. Yeah, so that can be difficult. I agree that communication can be a problem. One of the things that is on one of the slides is about whether you can get ambulance services to engage with that, because they may be with somebody at home that can actually provide that information. And if it's possible for that person to be sort of pre-alerted on their way to assessment, then they may even be able to miss out the ED altogether. But I agree, it's not something that's without challenges, but I think it's essential for all of us to try to recognise frailty. These are the 8 sites. So there's 1 in each region of England, 2 in London. And so they are working on this right now, but there is a keenness, I think, for other sites to look at these principles and see what they can take on board. And if you want to know more about it, you can get in touch with Fiona Wisniewski or Adam Brunning, who are running this project, and they will be happy to sort of give you more information. But yeah, certainly keen to discuss what people's thoughts are about this as we go along. I'm just going to talk a little bit about realistic change. So I'm going to mention huddles because they're something I think are really important, and I think they can be done well and not so well. Something about defining people's needs better, being more sophisticated in the way that we do that. And then getting into, OK, you've got this resource, what could you do to make better use of it? So huddles, do they make a difference? I'm going to talk a bit about language and touch on how you make your actions from a huddle more effective. So this is from our trust. So we had it was effectively a sort of a winter ward or an escalation ward, you might call it. It was opened up. Patients were under a stack of different teams, and length of stay was pretty long. And literally all we did at first was to assign somebody to do a huddle each morning. Most of the time it was a geriatrician, sometimes it was a respiratory physician, but you can see that within 6 weeks length of stay dropped from 8 days to 5 days. And so we feel that that is really good evidence that in this particular location, having that rigor, somebody just asking the right questions can make a big difference for a relatively low cost in terms of impact on other services and other people's time. When you're doing a huddle, there is language that can be helpful and there's language that can be unhelpful to moving the process forward. So the sort of things that can be unhelpful are talking about not back to baseline, it's very difficult to define what the baseline is, and it tends to lead us to hold on to people longer than is perhaps necessary. We all know what we're trying to say, you know, so somebody hasn't fully recovered, but perhaps maybe asking a question about how mobile do they need to be in order to go home or to leave this ward. Those sort of questions probably lead us to the answers that are going to be helpful. Don't say continue IV diuretic, but perhaps give some more objective wording that perhaps junior team members could follow. So you might say continue oral or switch to oral diuretic when they have lost 4 kilograms, or you might even go further, say, or if has not lost 4 kilograms by this date, reassess. Something like that gives a more precise thing that people can actually say, okay, because ultimately, in the end, we do make these decisions. So it's about trying to understand what are the factors that I would use to make that decision down the line. Check if safe at home. So the word safe is very binary. You're either safe or you're unsafe. And actually, life is a continuum. We've seen that being in hospital is neither safe nor unsafe, but there are risks. So a good way of asking that sort of thing is say, how confident are we? I find that a really helpful term in all sorts of areas, and it kind of gets away from that forcing people into a yes or no. So that gets you into a more nuanced situation where we can say, okay, well, now we can talk about balancing the risks. And rather than saying this person needs to stay in hospital because of this risk, recognize the risk and say, okay, how do we mitigate for that risk? So it might be something that we need to do at home. It might be something that we need to refer for. So, you know, we had a guy in recently who was admitted after trying to climb out of his upstairs bathroom window, which, you know, was a risk, a concern. And he ended up staying in hospital for over a month, and in fact developed delirium and ended up having to go for a period of care home support for a little while. And actually probably what he needed was a lock to the upstairs bathroom window. So it's really trying to understand about what is the risk, what can we do to mitigate that risk. But when you start talking about things like upstairs bathroom windows, then people quite rightly say, well, what about if there's a fire? So here's some useful information to keep in your back pocket. So in 2021, there were just over 27,000 house fires in England, and there are 24.7 million domestic properties in England. So that is 0.11% of properties had a house fire in 2021. And just remember, compare that with the risk of dying during a 7 to 13 day spell in hospital is 7.4%. So you're looking at a 1 in 900 risk of a house fire in a year against a 1 in 13.5 risk of death in hospital in a week. So often useful to sort of keep these things balanced. It doesn't mean that it's always going to be the right person, right idea to send that particular person home, but it can help the discussion to be able to say, well, here's a couple of options, here's some data. So a word on defining what people need. So there are probably sort of 3 main types of need that people might have. So they might need supervision, they might need treatment, and they might need a diagnosis. Those are 3 things that hospitals often provide. So the supervision could be close medical supervision. So these are people that have got a risk of life-threatening deterioration imminently, and they probably need to be in hospital. On the other hand, they might have a medical issue that requires some monitoring, but maybe it doesn't need to be minute-to-minute monitoring. And there you can start thinking about, well, okay, if they need monitoring, how else might we do that? And we could look at things like virtual wards and other options, coming back to a hot clinic, for instance. And then there are the sort of non-clinical monitoring, so perhaps somebody who's got behaviour that puts them or others at risk. And again, if that's what they need, then hospital probably isn't, in most situations, the best place for that to happen. If you look at treatment, then there are essential inpatient treatments that need to happen today. So these are things like operations that need to happen now, perhaps complex intravenous antibiotic treatments that can't be given outside of the hospital, whereas there are other treatments, and you might consider carer support in a way as a form of treatment. We are providing something for that person. And again, those things don't require you to be in hospital. And then diagnosis, trying to break that down into urgent diagnosis for a life-threatening problem. We need that diagnosis today, and without that, there's going to be a major issue, versus other things. And so if you think that somebody might have cancer, well, you want that information quickly. And typically for an outpatient, we would look at people getting diagnosed within 2 weeks or that sort of thing. So if you can break down what that person actually needs and try and understand the level of severity of each of those things, then you can start to have conversations about whether this needs to be done as an inpatient, or actually whether it might be better done following discharge. And you know, if you speak to a radiologist, you will hear about the huge numbers of staging CTs that are done on inpatients just because they're there, and that is one way of looking at doing that thing differently. Okay, a word on making the best use of what you've already got. So, you know, teams are stretched. We're not going to be able to magic up, you know, a couple of extra geriatricians for every trust. And right on time, a question has popped up. So if there are only 2 geriatricians in a hospital, how and where are they best used? So that is the question, and we might get into that a bit more in discussion. So this is all about the economic principle of marginal utility. So marginal utility is what is the additional benefit of one additional unit of a service, and that's what essentially we're trying to work out. If we do one more of something, what's going to have the greatest impact? So the starting point is to say, are geriatricians where you work seeing people living with frailty close to the point of admission? Are they getting stuck in that first 24-hour period, or actually are they only seeing people later on? So if the answer is later on, then it's certainly worth saying, okay, what can we do to push that forwards? And we'll perhaps look at some ways that might happen. And you've got a very small team. We can't provide an all singing, all dancing frailty service. There's only 2 of us. How on earth are we going to make things work? So a couple of things. So one might be to start with a narrower clinical frailty score target, because there's the saying that perfect is the enemy of good, or the enemy of better. And if you wait until you've got enough geriatricians to be able to provide the service that you truly aspire to provide, then you may miss out on helping a great deal of people along the way. So what you might be able to do is to limit the demand on your service by initially starting with a narrower clinical frailty score target. So if so a lot of frailty services will look at people with scores from 4 to 7. You might say, okay, well, we're going to focus on 6 and 7. And in fact, that's, I guess, what the Frail strategy is sort of saying. So think about, can we focus on a smaller group of people in order to be able to do something valuable? The other thing, if you've got a small team, and in fact, I was on a visit yesterday to a trust that is with essentially one geriatrician trying to do exactly what I'm talking about, which is front door frailty assessment. The way that they've done that, in a way that I'm sure Jyothi will talk about soon, is they actually released people from looking after inpatient wards by getting locums to cover the inpatients, freeing up the geriatricians to see people nearer the front door. So the theory behind that is that their impact is going to be sufficiently great that it pushes people into that more controllable length of stay. So one issue is the inpatient ward and clinic demands. Yeah, so clinics, there'll be a decision to be made about, there's a decision to make about how best to use that time. But yeah, specifically, places that have implemented this very successfully, including South Warwickshire, have used backfill to cover the ward to free that time up. I think if you're going to do that, you need to be, as an organisation, monitoring what's happening on those backfilled wards. Are there still huddles that are of high quality? Is the length of stay creeping up? But essentially freeing up that expert time, which fits in with what we've been hearing in some of the other webinars earlier in the day, getting that specialist input earlier may well make a big difference. Ask yourself, are your processes impairing other teams' abilities? So I remember going to a visit to a large teaching hospital, and they had a brilliant emergency department with loads of cubicles, and everything was set out really well. So you've got great sort of lines of sight and everything around the department. But 50% of the cubicles had frail older people waiting for an assessment. And actually, just down the corridor, they had a frailty unit, but they wanted to keep the people in the emergency department because I think, well, it was partly to do with liking the idea of turning around and preventing what they perceived as an admission. But actually, it meant that this big city was running on half of an emergency department. So is the way that you do things stopping particularly emergency departments to do what they are best able to do? So look to move people away from the ED. How can you do that? Where can you do these assessments in a way that's probably going to be a better environment for the person that's having the assessment, but also allows the ED to do what they're meant to do? And then think about what can you do to avoid unhelpful admissions. And the list is long, and it's about picking out maybe what's the thing that we're not doing that would add the most value. So this includes things like, you might want to try virtual MDTs for community frailty service or care home residents, or it could be a, if you don't have a consultant connect line for people in the community or primary care to discuss patients that they would otherwise admit. These sorts of things. What could you do that would add some value at the sort of minimum impact to the rest of your important service? Okay, so I'm going to stop talking in a second, which gives us 20 minutes to sort of have a discussion. So a summary. So remember and talk often in your clinical conversations about the risks faced by frail older people in hospital, because that enables people to genuinely weigh up and see where the risk lies. There's an expression I absolutely hate, which is risk aversion, and that implies that there is an option that's risky that we should be taking more often, and another option that's less risky, and it's not risk aversion, it's risk unawareness or even risk blindness. So talking about these sort of data can enable people to say, okay, do you know what, this is a high risk situation, how can we minimize that risk? So think about what you could do in your organization to allow CGA, including geriatrician input, to happen earlier. So that might mean backfilling, and there are examples of that having been done very successfully and continue to happen now. Think about what would add the most value, particularly if you've got a very small team. So there is an amount of value that will come out of the number of geriatricians or the number of other professionals that you've got in your team, but actually by deploying it in the right way, you may get the most. There absolutely will not be enough consultant geriatricians to do everything, and as Adrian Hopper has put in, thinking about your workforce, getting the right person to do the right thing is certainly really valuable. I often talk about what I call the head chef model of a ward round, for instance. So if you go to a restaurant, the head chef does not do every single bit of the food preparation and cooking, but they oversee what's happened. And so what you can do at your huddles is you can work out which member of the team can do each of the tasks that are assigned for that day. And yeah, that will come from people with a variety of professions. So that's a really important point, actually. Huddles really matter, and doing them well makes a difference. So think about how you're setting criteria, think about the sort of language that you're using, and practice how you define people's needs. So try and think about them in those sort of 3 domains, and whether they are sufficiently severe that hospital is the right place for that need to be addressed. So at that point, I'm going to stop there, and I can see that Nick is planning to go back into Menti in just a second, so I'll hand over to Nick for that.
Thank you, Richard. That's fascinating as always. Always helpful to get the old brains working at 4 o'clock in the afternoon, and you definitely do that in some of your thinking. So we are going to go back to Menti. There's a couple of questions some of you already started posting. I think this is a helpful way to maybe draw out a few more questions or a few more observations. I'm going to share my screen so everybody can see it. There's a few more comments going in already, which is really great. So the first question that we asked, in terms of what you've heard from Richard and in your own areas, what are the key interventions which will help achieve your desired outcomes in your area? So you've heard from Richard some really great ideas there from his own organisation and from others. What are the interventions that you require in your area? So Richard, Jyothi, you've got a couple of points there being made already. Any comments?
I think Richard has already mentioned about this assessing outside ED and freeing up the ED so that it flows well. Richard, any other comments? And I can see that on the chat we've got some really distinguished members of the frailty community and the care of the lilies, BGS and stuff like that. So anyone wants to come on camera and have a chat?
So I like the raising the profile of frailty to make it an organisational priority. I think that is a really important message. And for anybody that wasn't in the last session on acute medicine, one of the really strong messages that came through that I think applies just as much here is you've got to keep your SDECs open. So if you've got a non-bedded frailty area, putting beds into it is definitely harming your ability to appropriately assess people in a way that helps them to get home. And I know it's really hard at 2 in the morning when there's don't seem to be any beds anywhere, but whenever you do that, you are creating you're diminishing your ability to actually do what your organization's meant to do. Frailty is everybody's business. Yeah, absolutely. Yeah. It's because it's everywhere. The more people that can have CGA on their way into hospital, if they have to stay in, it means that the benefits of that CGA will carry through with them during their time in hospital, hopefully. But actually, people do need to recognise it and understand the sort of some of the data as well as talking about.
Lucy, is there any other comment in the chat or have you got a hand up? Have we?
Yeah, we have a hand up. I just wanted to point out about the frailty is getting the strong backing from the executive team. That's really important because 13% of the population of over 70s actually occupy 66% of our beds, and the frailty units and frailty teams get criticized because once they've done an investment in frailty, they only see a few patients. So the number of patients that they see are few, but actually it makes a big difference to the bed occupancy if you get it right. So this is something that the executive team sometimes fail to recognize. So I really want the executive teams to see that yes, it's a big team, may see small numbers, but will actually make a big difference in your bed occupation if you get it right at the front end. So I've got Jagdeep on the, she's raised her hand. Jagdeep, do you want to talk? What's your question?
Yeah. Thanks, Jyothi. I think kind of mine's a slightly broader question as to the purposes of specialty in-reach webinars such as this, because of course there's lots of work going on at NHSE, at Aging Well programme, as well as with the British Geriatric Society. And maybe I missed the start of the webinar, but I'm not kind of sure here what we're trying to do through this webinar. Are you asking us as specialists in the area to be supporting the strategy around this, operationalizing the strategy, or is this meant to be an educational event for clinicians, in which case we need to have a different approach. So I think at the minute it feels like we're doing a little bit of each one of those, but we haven't got clarity on it, and therefore it makes it really difficult for us to know from the BGS how we can support this in an effective manner. I think everybody on this call knows that frailty is bad for you. I don't think we need to be rehashing those conversations. I think we all know that the pathways need to change to match the needs of the current population. But what is it at NHSE now that we can do from our associations and the specialties to be able to support translating this work into practice? And if this is a webinar for educational purposes, then we need to have a different marketing approach to this, because we've got 33 people on the call today. We've got 159 clinical leads for geriatric medicine across the country. Having chatted to them over the weekend, not many people had heard about the seminar happening today. And so it's not surprising we've only got 33 people on the call, which, you know, isn't a great use of your time as kind of on an organisational basis, or of clinicians' time either. So I think we need to have a little bit of a rethink around the purpose of these events and how we make them more useful for everybody. So it's more of a general comment as opposed to how do we embed CFS at the front door, or how do we restructure the workforce? Because I think we need to get the first bit clearer.
Okay, shall I take that?
Yeah, go for it.
Yeah, okay. So basically, thank you for the question. And we have taken on board that advertising really didn't, we could have done better with advertising and also given a bit more time in the development of it. So this is the UEC transformation team, which has got two areas to work at. One is it's admitted pathways program, and it also has specialty in reach as part of its remit. So we were asked to develop seminars, especially for specialty in reach. So, and look at how various, and also the specialties themselves had a lot of guidance, but they were welcoming a national push on this. And I know it's being done through other areas as well. But we took the 5 high volume specialties for the admitted pathways. The 5 high volume ones are surgery, medicine first, but within medicine, it was care of the elderly, respiratory, cardiology, acute medicine, and in the surgical faculty, it was general surgery and urology. So we took these 5 high volume specialties, and we were pushing the national guidance that the specialty has already developed through to the clinicians and organizations. That was the first remit. The second remit is to see how people have actually implemented these guidance using very innovative ways of, or some new workforce solutions. And the third thing is, the one thing that patients wait for in EDs is usually that early senior specialist, decision making and ownership. And there are people who have actually done it very well by increasing the, how they have built that into job plans, how they have actually done clever rostering and made that happen. So they've got much better access to and easier access to this high quality decision making at the end of the phone. So there is room for lots of different things. And you're absolutely right that we could have advertised it much better. And we could have actually, you're right. We've already taken that on board. So,
and I think it's partly the advertising, Jyothi, and of course we're really happy to help with that from the BGS. But the other bit that I feel is missing is the overarching strategy around this, in that we have got different programs of work going on without what isn't visible to us on the shop floor is how all of these programs are linking together, GERFT with NHS England, with all the frailty work that goes on at the BGS and through the RCP. So it feels like there's lots of people working on this very piecemeal and that we don't have an overarching strategy on it. So it'd be really interesting to hear how the Aging Well programme is taking leadership on this, or how are we actually pulling this together? Because absolutely at the BGS, we want to be supporting this work because it's our bread and butter. And, this is where geriatricians are the experts in delivering this wherever we're looking at this, if it's in the community front door or on the wards. So I think it's the strategy bit that we're really kind of wanting to see on paper.
Absolutely. And as I said, this is the length of stay program. So this is the admitted pathway. So that's our remit. And so it does fit into the whole UEC strategy. And we can share that with you. Nick, you were saying something?
I was just going to say thanks, but I'm conscious of time that it's only got 10 minutes, less than 10 minutes left. And just when there's anybody else on the call, we've got a couple of comments in the chat, Lucy, from Adrian and Ben. I don't know if they wanted to pick up any comments as well, just mindful of time.
Yeah, do you want me to read those out? So so we don't have any questions in the chat other than ones that have already been picked up by Richard, but a couple of comments. So Adrian just made a comment about the GERF report recommending that trust should have a responsible officer for frailty reporting to the board. And Benjamin Owens, he made the comment about what matters to the patient. So he was saying that we're worrying about frail patients being safe, but the majority of frail patients fear the loss of independence over death. So we need to focus on what matters to me.
I can see Adrian on the screen. I don't know if you wanted to take that any further, Adrian, or just start a conversation on that.
Well, there is the thing, a bit like Jagdeep was saying, where do you start with this and all these interlocking agendas? So the workforce is key. I mean, we see that in the GERF visits, but the other striking thing is, the typical variation between trusts is a factor of 2. We've seen examples of huge infrastructure and investments in acute frailty teams and performance getting worse. So there is always a local ingredient that needs to be looked at. So, I mean, that's the sort of overarching thing is there are these structural things, but and the striking thing at a national level is how little, Jyothi being a notable exception and South Warwickshire being a notable exception, but how little just, standard quality improvement is applied. Most hospitals are running these services without any idea of what their performance is like and their overarching data, and it's crazy. You'll never run something effectively unless you know where you are and how you're trying to improve it. So there's a number of interlocking themes, and I guess just the thing is how much variation there is. And one other just more clinical theme is, and I thought your data on death and so on, Richard, was fantastic, but Sheila Reardon mentioned in her virtual ward, her patients mentioned to me 25% 1 month mortality of patients on virtual ward. So a systematic approach to end-of-life care with advanced care planning is, I think, in our world just really, really important, because wherever patients are, they are in the last phase of life, and there's precious few examples of anywhere doing that well, and that has to be the combination of doing it as well as everyone being able to see what the output of advanced care planning is.
Yeah, thanks, Adrian. Really helpful. Ben, do you want to come in?
Ben, yeah.
Hi, yeah, Ben Owens, ED consultant, Sherwood Forest and ECIST associate. I think a couple of things for me. I thought great presentation, Richard, as expected. I think this for me, a lot of this is around the patient, and there's also the hospital system. So this is prevention is better than cure. You can't be a 3-month length stay in hospital if you don't get in the door in the first place. So it's better for the patient, and better. It's trying to far better to stop people smoking than try and cure lung cancer. So actually, this is about early intervention. If you haven't got enough geriatricians, then actually we can educate our emergency physicians, our acute physicians, we can educate our junior doctors and our therapists as well about all those risks that Richard mentioned so well. And I think the way I look at it is there's the brand tool. So do we actually honestly say to frail old people coming into hospital, either in the ED or actually if they get in the front door, if they're in that first, because we know if they get past that, off that admissions unit, any care package will be stood down and you're immediately creating a long length of stay patient. Do we actually honestly go, these are the benefits, these are the risks, these are the alternatives, and we could do nothing to send you home? And there's the brand tool, and I've changed it myself slightly now to BRAM, B-R-A-M. Actually, what are the mitigations? So we are anxious about sending frail old people home, and we are anxious about things going wrong. Actually, we're going to send you home. These are the risks, your choice. But what mitigations can we put in place? Can we give safety netting advice? Can we get relatives? Can we get community teams involved? Give the patient the choice and ask them what matters to them. And because if we don't do that, they will become long-stay, and the mortality figures are horrific. And if those are mortality figures for a kind of cancer, then there'd be a huge process in place for a 40% mortality 1 year for that kind of thing. And these are that's the same mortality risk for those others. So I think educating teams, having a culture shift towards not admitting, about discussing or highlighting those patients, so when they are admitted, the first thing the next morning, someone goes, right, this patient has potential to go home. And other trusts have managed to do that.
Thanks, Ben. I'm conscious of time, so I'm going to hand back to Jyothi just to wrap things up. Thank you, everybody, for attending today.
Thank you, Richard. Very insightful, and thank you all the audience for taking your time to attend.